Hello, everyone. My name is Samer Sbayi. I'm a general surgeon and faculty at Stony Brook University Hospital. I'm here to present to you what happened, the aftermath part 2, how to handle a wrong site surgery event. I also run the emergency general surgery service there, and I also run a fellowship. I have nothing to disclose. Let's watch and listen carefully here. This is actually one of my cases. We are currently prepping and draping. Here comes the local anesthetic. Now I use 0.125% Marcaine. I find out what the 0.25% maximum dose is for the patient, dilute it with an equal amount of saline, which provides me an increased amount of volume. Let's listen to this timeout.
Open right inguinal hernia repair, open epigastric hernia repair. He has no drug allergies and he got one grit on the inside.
Did you catch it? Basically, there is a difference between these two pictures. The right side, the correct side is marked, and the side that has the incision is obviously the wrong side. This is a 65-year-old male who presented for an elective hernia repair. He came in for 2 repairs, the right side inguinal hernia and an epigastric. The anatomical site was marked in the holding room. This was verbally verified by anesthesia. And in the OR, the circulator was preparing the tumescent anesthesia mixture, which I just mentioned, which was my diluted form of 0.25% Marcaine. The patient was draped. The timeout was performed. And there's agreement that this was the epigastric and right inguinal hernia repair. As the nurse was preparing the anesthesia mixture, the local anesthetic, I went on to prep and drape the patient. Usually the nurse does it for us. I stood on the left side of the patient, which is not my habit. The incision was made on the left groin. A small hernia was repaired, but I did note that the hernia was smaller than expected, and then the epigastric hernia was repaired. Postoperatively, the patient noted that he had an incision on the left side. I did receive a phone call stating that the patient is questioning why is there an incision on the left side. And the first and most important huddle in my life was conducted. I was off-site. I was at an opening for our off-site clinical sites. And I was in the company of my chairman and also the director of the ambulatory surgery location where I actually performed the surgery. As I received the phone call, so did the director of the ambulatory surgical site. And we basically discussed the situation, which was very, very helpful from my respect, because the first thing that I considered was this was very traumatic, and it was a shock. It was very helpful to be in the company of these 2 individuals who basically assisted me in navigating the next few steps that we went through. So the plan was that I would meet with the ambulatory director at the surgical center, and we would offer the patient a corrective surgery. But again, there was a lot to be done before we actually get to there. The second huddle happened at the ambulatory surgery center. The risk management coordinator was there. The nursing director was there. The designated institutional officer was there, who basically represents the graduate medical education programs. The director was there of the ambulatory center. The nursing manager was there. The anesthesia provider and the CRNA, as well as the circulating nurse and the scrub nurse and the resident. And you can only imagine what the atmosphere was like. It was silent. And basically, our risk management coordinator had actually guided us through the discussion, along with the director of the ambulatory center. We discussed the circumstances, the current situation, and myself and the director of the ambulatory center basically walked to the patient in the recovery room and had a discussion with his wife. Full disclosure, nothing but the truth had come out. I had fully disclosed that an error had taken place. I had also explained the consequences of this error. I did explain I did find a smaller hernia, and it wasn't what I was expecting. I do recall on exam that this was a bigger hernia. We had a long discussion. I did a lot of listening. I answered a lot of questions. And then we offered the corrective measures, which was basically keeping the ambulatory center open after hours, waiting for the anesthesia to wear off so he can sign his consent again, and offer him the corrective procedure and to stay overnight at the hospital. This, of course, is usually an outpatient procedure. Surprisingly and gratefully, the patient was comfortable to allow us to do that. And he and his wife had actually admitted that we trust you, which, considering what had happened, was amazing. Needless to say, the patient underwent the procedure, the corrective procedure, uneventfully. He recovered well and was discharged. He was also explained that all the costs would be covered. He would not receive a bill about anything. His wife stayed at an overnight hotel. They were actually from a distance, about 5 hours away, and they had come specifically to have this procedure done. We had some close follow-ups with the patient via telephone, myself and the director of the ambulatory center. We kept close contact. They continued to be pleased with everything that was being done, and they were also very grateful. The patient followed up in a couple of weeks and was doing well. This, the next steps actually was this was presented in M&M, and I presented it to my colleagues, including we also had senior leadership from the hospital, which usually aren't present, but considering the circumstances, they were there. My colleagues were very supportive, which I was deeply grateful for. Many of them would actually say this could have happened to any one of us. And during the root cause analysis, which was basically a committee of many people at all levels who got into a room and broke down the whole process. And we identified the gaps. Universal protocol was not followed as intended. This was a protocol that was put out by the Joint Commission in 2003. The surgical site needed to be confirmed, and it was confirmed only verbally by staff after the surgeon had marked it. The surgical mark needed to remain in the surgical field after draping, and you noted, or you clearly saw that during the draping period it was covered. This was not spelled out in the policy. The drapes covered the surgical mark, despite the correct site being verbalized during the timeout. What are the actions that ensued after that? In addition to contacting my malpractice coverage and discussing options with them, we also came out with a revision of the universal protocol. Clearly, this needed to be amended. The anesthesiologist and nurse needed to verify the correct patient procedure site inside and visualize the surgical mark in the preoperative area. In the OR during the timeout, before the first instrument was passed, the surgeon will ask, can everyone see my mark? And wait for all team members to verbally confirm. And this is actually happening seamlessly right now. We ensured compliance. And to do that, education was provided at all levels regarding the changes. And this was basically across the whole general surgery department and the OR, including the ambulatory center and the main OR at the university hospital. The audit included 70 surgeries were observed for compliance. The audits continued for about 4 months. This was the responsibility of the Department of Surgery, led by my chairman. The operating room had a mandatory crew resource management course, which was held by Life Wings. And every single individual in the operating rooms, including the Department of Surgery, attended this. And then finally, a report was sent to the Department of Health, which is a requirement as well. Wrong site surgery, definitely recognized. The American College of Surgeons has a pamphlet that explains the communication that needs to happen between myself and the patient, and myself and my colleagues as we set up for this procedure. This is available on their website. This is definitely a never event. The wrong site involves wrong person, can be the wrong organ or limb, and it could be the wrong vertebral level. A survey in 1999 of hand surgeons showed that they actually admitted to experiencing at least one of these events. 21%. And 21% have reported this. And this included mostly wrong finger. And these were 242 incidents. And so the estimate of this occurring was 1 in 28,000, almost 28,000 cases. Additionally, 22 medical malpractice insurance covering 110,000 physicians. When they looked back at their claims, and they found that 331 claims over 10 years involved a wrong site surgery. JCAHO had a summit in 2003 after having a root cause analysis of 126 cases that were presented to them. They presented as 13% wrong patient, 11% wrong procedure, 76% wrong body, part, or site. And they identified the risk factors, which kind of makes sense. It is the life that we lead in our busy obligations. Emergency surgery, time pressures. All of us can admit to the time pressures, whether it's starting on time, starting late, not finishing on time, trying to finish on time to get to something else, the clinic, another surgery, to see a patient, to finish rounding a personal event, catching the soccer game. These are real pressures. And then the other risk factor is multiple surgeons, having more than one surgeon in the room, and multiple procedures in a single surgery visit, which can be, more than one lipoma, a bilateral inguinal hernia, or a hernia in the epigastrium, an umbilical hernia, all done this at the same time. So the University protocol that came out in 2003 basically is available on their website. If you look at the Joint Commission's website, it's available there to share, and it's quite detailed, and it's for preventing such occurrences. And the minimum 3 requirements that were found to be the most useful in order to minimize this occurrence was preoperative verification, site marking, and timeout. Risk reductions. What could help? We have to understand where wrong site surgery risks lurk in our perioperative setting. And that is the truth of the matter. It could be anywhere from the initial visit in the clinic, to scheduling, to preoperative services evaluation, to getting blood work, getting a preoperative image, in the holding room before surgery. It's recommended to make your patient part of the timeout. So once they get into the OR, involve your patient. Very helpful. It's a mandatory pause. It's difficult to ignore that, action. There's so much going on in our heads that when this pause is taken, a complete dedication to this is committed, so that it is taken seriously. Include and involve every member of your team. During my timeout, usually I we'll do team introductions, and I'll go to each person. They'll introduce themselves and the role. And then we'll have anesthesia talk about their issues with, what they had for general anesthesia and the allergies. And then the circulator will discuss the issues as well, the positioning, straps across the patient. Where is the grounding pad? Was there an arm tucked? What anesthetic are we using for local? The scrub nurse will talk about the instruments and ensuring that everything is sterile. And then at the end, I usually will ask them to not hesitate to speak up, which is a big deal as well. We have to encourage a speak up culture. And it's important to track and audit how well we're doing. And that's where mostly the learning can happen. We have to identify how well we're doing and where we can actually improve. Reviewing the literature, we can see what the incidence is, and it's basically in one paper looking at 1 in 112,000 patients. These were non-spine surgeries. This was looked at something over 20 years, 3 million operations between 1985 and 2004. And a total of 25 cases were identified. 12 wrong side, 12 wrong site, 1 wrong patient, 2 were during emergencies, and most injuries were temporary, thankfully, or minor. What are the contributing factors, and are they preventable? Of 13 procedures that they looked at specifically were non-spine cases that were reviewed in detail. 9 involved ambiguity or error that preceded the arrival of the patient at the OR day of surgery. And this is basically all the preoperative, journey of the patient. And they identified that 4 happened in scheduling. And you wonder, well, okay, they received the clinic notes and the consent, and perhaps there was an data entry error. 3 multiple lesions were not identified or clarified or documented at the clinic visit. Multiple lesions need to be identified in the clinic note and the consent. 1 incorrectly printed MRI image. And we can all see how this can easily happen, or it has happened. We've caught it. The wrong image was placed up. We put the wrong image up in the OR, or the resident did. We didn't take the time to review it or review the consent. This doesn't make sense. This is not the right image. This is not the right image. Let's check the right image. 1 clinic note and consent form specifying the incorrect side. Again, the necessity of sort of verifying with the patient. Is this the right side? Going through line by line with the patient, take the time to do that, despite the time pressures. Site and or side was not specified in 6 of the 9 consent forms reviewed. 4 of the 13 were preventable by review of the radiological films or reports. Again, taking the time to review the film, checking the consent, reviewing the clinic note, and then finding out we are doing the right thing today. And 2 of these findings, they weren't available in the operating room. So again, ensuring that the right information is available for review at the time of the operation. And all this can only happen if we really, really and truly take a pause. The incidence, it can happen once in every 5 to 10 years at the larger hospitals. It is not as common as foreign body retention. When you review the protocols, they vary from one institution to the next. There's really not much published about the effectiveness of site verification interventions. What happens when we don't find the right consent or the wrong date of birth is on it? Is there a policy? Does somebody know what to do next? Scrap the consent, redo it again in the holding room. What happens if the patient is asleep and the wrong consent was signed or the wrong procedure was signed for? What do we do next? This has happened. Written checklists are prone to error. So it is easy to skip steps. Why is that the case? Because there are multiple interruptions and distractions. It is so easy to check a box when even it wasn't completed. However, the redundancy can decrease error. And the only way for that to happen is that if we treat each and each and every individual line and step independently in the holding room, in the operating room, before we hand off an instrument, taking time to review the consent, the image, reviewing with everyone in the room, and ensuring that everyone is able to speak up. This involves actually detaching ourselves from the busy issues happening in our head, which needs to happen as part of the team. Protocol site marking processes, these have been reviewed, the same paper. 16 site verification protocols were reviewed from about 25 hospitals. This revealed a great deal of variability. It was variable in the sense of the site being marked, who should mark it, who's responsible. The surgeon marked it 12 out of 16 times. The patient marked, the diagram is marked, the resident or the designee marked. 14 of the 16 required a pause or timeout. All but one required this documented in the chart. This needs to be documented for future reference. 11 protocols had no mention of the site identification for spine surgery. Like, what level are we doing here, people? That's the question that needs to happen. Have we marked it? It can't be ambiguous. Our patients count on us being very, very particular and keeping them safe. And so the recommendations from this paper, at least, is that site marking needs to be addressed by a surgeon or a designee that marks the initials or a yes. This needs to be verified in the pre-op location, the identity, the procedure, the site, the side, and the vertebral level. 2 healthcare providers need to be there. A surgeon should be one of them. The OR schedule and informed consent should be compared by both staff members. The timeout provides the final confirmation, which is the pause. How do you deal with inconsistencies? There should be a process. The surgeon should resolve with agreement by patient and one other caregiver before the patient goes to sleep. Protocols should address how these are resolved. And then specify the laterality if the site is bilateral. Multiple structures. Booking should include equivalent detail. Errors begin before the patient's arrival for surgery. Clearly, this can happen. Ensure the correct site and side is documented in the clinic. We need to take the time to do that. Now, complications are many, but how do you recover? We have a great deal of burden like pilots do, and errors can be catastrophic. 1 in 10 patients could experience an adverse event. Surgery by far is the majority, and almost 8% are fatal. Medical errors are the 3rd leading cause of death worldwide after heart disease and cancer. What do patients want, and what do they need? We have to acknowledge that we have committed an error. This is the first step. They don't want to ask you questions. They don't want to do that. They want you to be completely transparent. And we find that 57% of surgeons are reluctant to use the word error. There's a failure to communicate honestly, which clearly leads to malpractice claims. There's a lack of remorse, and it gives the sense that we're hiding something. And the most common reasons for filing a lawsuit is failure to be available, devaluing the patient's or family's views, not listening, taking the time to sit down and allow them to vent and speak once you've been fully transparent with them. You need to sit down and listen. You need to acknowledge their expression of discomfort. You need to explain exactly what happened, how it happened, and how you're going to remedy this. There needs to be factual information and a sincere apology. It's important that the patient still trusts you, even if an error is committed. They trust you to do the right thing. And many do recognize that mistakes can happen, but they really care about ensuring that this does not happen again. So that's why it's important to acknowledge the mistake, say there was an error, and accept responsibility. And when do you do this? It's immediate. Give all the information. Was it equipment? Was it personnel? Was it we're being rushed? And then offer how changes will be put forward in order to prevent a repeat event of this. There is a model out there called the Michigan model, which basically has reverted to total open disclosure and immediate compensation and offer. So what do? They compensate quickly and equitably. They learn from the experience and they share this with the patient. And at the heart of this is what we've just discussed, is accountability, honesty, and consistency. We have to consider these as not as threats, but as an opportunity for change and improvement, and an obligation to our patients and community that they trust that we will do the right thing even when we do commit an error. In practicing this method and this model, they've noticed a decrease in the claims per year. They've noticed that the resolution was a lot more quicker, and that the amount of money per lawsuit was much more or less. Now we do have to consider the dramatic, experience that we experience as individuals. If we are considered the second victims who are involved in these adverse events, none of us wants to be the reason for a bad outcome in our patients. We are in this profession to help people. But unfortunately, we seem to be alienated and put into a corner as the individual has committed the mistake. And it feels that we've failed the patient. We start to second guess our clinical skills and knowledge base. And this gives you the sense that this is not a team effort, which is the exact opposite of what we're doing here. This is a team effort. It's a system, and the system has to protect each and every individual. And within the system, we have to function as individual units that actually work together to provide the patient the care that they're looking for. What is this emotional impact on the patient? 12% of surgeons have the impaired ability to perform their job. It is so traumatic. 2% have avoided certain procedures. Many have expressed difficulty concentrating in a survey, declining clinical judgment, loss of confidence. There's trouble sleeping, difficulty enjoying leisurely and daily life, symptoms that are in exact alignment with depression. There's frustration, embarrassment, anger, blame, worry about reputation, reduced job satisfaction. This is certainly more common in general surgeons. And we are more sensitive to burnout. Strategies that are implemented in a structured format or not, but clearly there's defensive strategies that we express immediately upon finding out this event has happened. There's denial. How can that happen? There's discounting. There's distancing, whether we distance ourselves from the event itself or people distance themselves from us. There's chaos and accident response. Sometimes it's not very organized. I feel very fortunate that I was able to lean on individuals in the department that were able to carry me through this in a manner where they can actually lead me through the process that made sense. And it needs that leadership and that collegiality to actually recover and to recover from the event and, provide the right care and how to provide it as a team, and then to recover on an individual level by people sharing their own experiences. Clearly, there are reflections that are intrusive. There's a concern about restoring personal integrity. You feel like that this inquisition goes on and on sometimes, and it doesn't stop. There's a necessity to obtain or consider the emotional side of this. Sometimes we just feel like we're robots and, we can move on to the next thing. But it does tend to build up and lead to some of the symptoms that we saw in the previous slide. And then the question is, how do you move on? 4 phases are delineated in literature. have described the different phases of, encountering this event and how it's processed and moves forward. Clearly, there's the kick, where's the initial shock, the tachycardia, anxiety, the fall, the negative cloud of, what's my worth? There's a problem with integrity. The emotional well-being is also affected. The recovery involves discussing details and the emotional impact on individuals. The details seem to be easier to discuss than the emotional impact, and I think that needs to be more of a concerted effort on how do physicians who go through this anxiety each day, trying to avoid any errors, how do you sort of bring out the emotional side and sort of help the healing there? And then there's the long-term impact, and that could be positive or negative. This could be a learning experience where we're able to actually learn from it, do better, and teach others. Or it may be someone may need to limit their practice. And always keeping in mind that there's a dichotomy of the need for us to be perfect. And, we're not perfect. We are perfect as a group. And the facility of disclosing an error. We need to be comfortable in when it does happen, we need to disclose it to our patients who completely depend on us for doing the right thing and keeping them safe. As a reference, I found two great references here. One of them is a YouTube video by Carol Ann Moulton. She's at the University of Toronto, and she talks about curing surgery mistakes and goes into some detail about pauses. It's a very interesting video. It's very short. And the second one is a TED Talk by Dr. Brian Golden, also from Toronto, who discusses an experience that he went through and his perspective on this and how he basically bounced from that. Very interesting perspectives. Thank you for your time, and thank you for Sages to offering me the opportunity to share this talk with you.